And I have 12 o'clock noon. This is Becky Royer. I'm the lead for the Medicare Beneficiary Quality Improvement Project, where we provide swingbed education and technical assistance through the State Office of Rural Health's Flex Grant Program. Want to thank both Joyce Fillenworth and David Conrad for all of their support and providing the swingbed funds for us to be able to provide some ongoing work with you to build your programs. And also would like to thank Carolyn Miller from the Indiana Rural Health Association for supporting Zoom for us today while Allie Orwig is out. I'd like for you to click the button below. If you hover at the bottom of your Zoom screen, you can open up the participant list and you can see others that are on the call. Likewise, you can mute and unmute yourself in this particular list by clicking the red microphone button. So feel free at any time. This is an informal type of presentation, so feel free to jump in and ask questions. I will also be monitoring chat. I encourage you to hover at the bottom of your screen and open up the chat function so you can see chat questions as they come in. And again, more than welcome to chat in any questions and I will make sure that they are addressed. So want to introduce to those on the call that may not know her, but we've been working with Kerry Dunning, who is a national expert on post-acute care and particularly swing beds for critical access hospitals, and worked with a number of other hospitals in many states. She's been with us for a couple of years now, and her knowledge and wealth and connection with CMS to give us the latest and greatest updates has definitely been welcome. So Kerry's going to provide us a swing bed update today on the public health emergency and some other audits that are going on that you really need to be aware of. So Kerry, I will turn it over to you.
Thank you, Becky. It's always a pleasure to join you guys. And as Becky said, if you have questions, please chat them in because we're going to cover some odds and ends. I'm going to start with the what they call a PHE, or the public health emergency. This, surprisingly, I probably get 4 to 5 emails a week from different people in different states saying, is the PHE still in place? And the answer is yes. It ends effectively April 16th unless it's extended. We're caught in no man's land, and you can read the information there that it obviously started in a prior administration and was renewed multiple times under the current Secretary of Health and Human Services. It's already been renewed several times. One of the things that they are supposed to provide is a 60-day notice before they end the PHE. Well, we're inside that 60 days, but I think everybody started getting nervous because I started getting more calls in the last 2 weeks because we've had less COVID. Now, not to be a downer, but I work internationally, and there are 5.
We have no speech therapist right now, and I don't think we're going to get one. I told him if this don't work, go to a recruiter.
Carolyn, I think we have someone that needs to be muted, please.
So they're supposed to give us 60 days notice before they don't renew it. We have been surprised because, as you know, probably more so in Indiana than any other state I work with, you got hit almost from the beginning of this round, and you stayed on the longest with the highest numbers. I know in the last, 3 weeks, Becky, the numbers have been dropping substantially, and that's true across the country. I do know the Chinese are back under full bore for another variant, and they're how can I say this politely? They're very specific on the rules there, and people can't go out right now. So that means there's a significant number. We also have 5 European countries including the United Kingdom, Spain, Italy, Germany, the Netherlands. I can't remember who the other one is right now, who have started to see an increase in a variant, a Delta variant. That doesn't mean it's out of control there. I will tell you one of the reasons I'm now glad they're not ending this. There are a lot of reasons I'm not, because it's going to cause us some rigmarole to go back to whatever we had as normal. But one is with the situation in the Ukraine and 2 million immigrants being found in other European countries, I'm really worried about the spread of one of the versions of this virus again. And I think Poland has taken in 85–90% of them. But I've been listening to the people, and there are a lot of them that are joining family members, for instance, in Spain or England or France. So we're going to have to watch this. For our day and time, we are expecting this to be renewed on April 16th, which would take us into the summer. And then we can figure out then what's happened with what's going on in China and Europe to see if we're going to have another variant of this. This is not on the sheet, but if you've noticed this week, we've already had 2 announcements of another booster that's going to be required. And it's the presidents of those drug companies that are actually announcing that. They have not announced when that date will be. If any of you were alive, you know, I'm one of those that was born in 1820, so I was around when they started the flu vaccines. They did almost the same pattern. It was not an annual booster. For many years, 2 or 3 years, let's put it that way, we had to get repeat flu shots. And I think we're following that pattern now, where we're going to have another booster that's required by whichever version that you've been given. And then we'll see if we can't settle this into a once a year, like a flu shot. There are a whole bunch of us that are hoping the flu shot and the the coronavirus end up in one booster instead of us having to have multiples. But here we are right now. It's in place. It has not gone away. Legally, it cannot go away because we're inside that 60 days. That means in the middle of July it'll be renewed. You can count 3 months out from that date, and that'll be the next time it will be up for renewal, and we'll just have to see pretty much what's going on in the world at that point. All right, so one of the other things I want to talk about, Becky and I've had some conversations with this, so I'm going to start with something that is not directly related to swing beds. Did you hear the not in there? Because it's important that you understand that you're on the edge of this. But if you have ever been under Joint Commission, they have what they call tracers. If they find issues in one area, they start tracing it into another department. So that's why I'm trying to give you a heads up. There is a type of CMS audit called a targeted probe and educate. It was meant truly when it was initiated. The probe part is reviewing usually about 10 charts in the first round. If they find errors, they stop and they educate that facility and staff on what errors they found and how they should correct them, and where it is in regulations. Like many things in the last couple of years, we've ended up with more punitive outcomes instead of just the education. I saw this starting now 2 weeks ago. I started getting calls from 2 states. This week I've got calls from 3 other states. None of them are Indiana yet. And it's not one nursing home. It is multiple nursing homes calling me. So they have started the targeted probe and education, or educate audits, which is the TPE. What this does is allows the MACs, and if you're not on the on the financial side, the MACs have been paid by Medicare to accept your claims and make payment back to providers and suppliers under the Medicare dollars. They are also one of the groups that can conduct Medicare audits. There are obviously other groups out there, other legal groups inside the U.S. government that can do this. So it was meant to be education. All of them that I've heard so far in the multiple states are keying in on how a person was admitted to a skilled nursing facility. And it's down to things like on a skilled nursing facility, one of the things that must be written in the orders is literally admit to skilled care. Literally, that has to be written. And where I'm worried about that backing up into your Swingbed programs is how we are transferring them, or how we're discharging them from your Swingbed program and then admitting them to skilled. I'm worried for a couple reasons. One is CMS typically now frowns on Swingbed to skilled nursing facility movement. They don't like parallel moves. This could be the same if somebody was going from one inpatient rehab facility to another inpatient rehab facility. They do not like parallel moves. They don't understand it. I know some of you do it because you keep people short stays, and that has been your process. That I would revisit. However, the other example I could give right now, depending on where we are with COVID in the nursing homes, we have nursing homes that didn't accept admissions, even of their own residents. So you kept them in a swing bed, and then you returned them at a skilled level to their own nursing home, which is their home, and they became long-term care residents. So make sure you're very clear in your documentation if you're sending them to a nursing home, what it is, and also make sure you don't have a pattern of, I'll say you just discharge after 7 days and almost all those discharges go to a skilled facility. That will pull you into this audit. So you need to look at your policies and look at your patterns and see what you're doing. So there are usually 3 rounds. They're looking at billing practices, but they're going back into the only way you can have a correct claim is if we got correct clinical documentation to the claim. For instance, the ICD-10s. And so it backs up into the facility. The first one is typically 10 charts, and I'm finding everybody, that's what they've been requested. The MACs are supposed to review it, and then they are to conduct an education session that those nursing home staff members must participate in. Then they're supposed to wait 45 days and do a second round. A second round typically is 45 claims instead of 10. If they have not corrected it, they will go to a third round. And if they find errors still, they take back money. They can put you on all sorts of sanctions. So you may be hearing from your nursing home that they need certain information from you. This may be what will cause it. Like I said, I have not seen this in Indiana yet. If any of you hear it among your nursing homes, if you let Becky know, that gives me a heads up to start watching your state for these kind of audits too, and typically what they're finding, what they're keying in on. But your nursing homes are going to be under some pressures. One of the things that seems unfair to me at this point is they have targeted 2020 and 2021. In which were 2 of the toughest years ever in all of our healthcare industry. So there are chances that we have errors on our claims. There are chances we don't have all the documentation we need. So it's going to be kind of a tough time. So the common claim errors they have for this, and the reason I'm bringing this up is you are you're under skilled regulations, even though you're a swing bed, which means they could elect to audit a swing bed program. I think it's more likely to be a rural health swing bed program than critical access, simply because the government is used to the MDS. That's one of the things they track. And that's what your rural, if you're a critical access, that's what your rural counterparts have to turn in. So they can backtrack the claim to the MDS to the facility. For yours, there's not that interim state. If they were to if they were to decide they were going to review you, they would be going strictly from your claim back in and asking for additional documentation. So the 4 main errors that they have found in TPEs for the last 2 years, actually 3 years now. One is the signature of the certifying physician. And that means that when there was a discharge from the hospital or a discharge from a swing bed to a nursing home, they are looking for the physician's signature for that discharge. And on their end, they're going to look for the physician's signature for admission to a skilled level of care in the nursing home. So make sure that signatures are being double checked. One of the oddities that I've heard now twice is they are looking at claims that were primarily for therapy patients, and they're not finding the in the immediate paperwork, in the admissions paperwork, a therapist having signed off on it. We really don't have a place directly for that. That's why that question is odd. We can work around it from the eval, but the eval doesn't always happen the day of admission or even the day after admission. So we're trying to figure that out, but they're going to be looking at all signatures. Second was encounter notes not supporting. And so this is where we need to have your help too. And I think you need to be wary, which is you need to look at the ICD-10s that are your primaries and what do your nursing notes, your therapy notes, your RT notes, your physician, your dietary, et cetera, say to support that that's the primary ICD-10 that Medicare should be paying for because they had this much need. So there is a chance your local nursing homes could contact you also for hospital documentation that supported that ICD-10 to be transferred or actually discharged and admitted to a skilled facility. Documentation does not meet medical necessity is the standard statement in every review going on and been every review for the last 5 to 7 years. They say they can't find the supporting documentation, particularly that, again, that supports the ICD-10. Remember, this is coming from claims, payment, and that's based on ICD-10, not just clinical. But you'll remember we've had several discussions about the importance, for instance, of second shift nursing, documenting the care that is needed to show there was a 24-hour need for nursing services. It is called skilled nursing for a reason, and it is an inpatient because that person needs 24-hour care. It will probably also be looking at our IDT meeting notes to make sure everybody was in the meeting and that the signatures were obtained from those that are in there as well as what was discussed. And the last one we've also talked about, which is the missing or incomplete certs and recerts. For swing beds, this has been a separate audit all unto itself. So I don't know if they'll stick to the separate audit or if they'll kind of group these 4 things under it since these are the majority of areas they are looking at. Let me remind you where I see the most chance for error, and I'm not trying to change whatever your process is, so please don't take this as there's only one way to do this. Normally in a nursing home, we have a form that's a physician certification form. The physician signs off on the initial certification. Then there is a recert required by day 14. As you know, it has questions that have to be answered. And in a nursing home, that can go out to 30, 60, and 90 days for required physician certs. I'm bringing that up because really for the first time that I know of since I've worked with swing beds, we have swing beds that need to be doing 30-day physician certifications because you've had COVID patients, you've had pulmonary patients still in great need, even though COVID may not, that they were secondary to COVID, but you have them because of respiratory issues or heart issues. So we're finding a number of swing beds that are keeping patients past that 30 days. So let me remind you that it, by law, has always been 14, the initial one, 14, 30, 60, and 90. Secondarily, let me remind you that those 4 questions on there, we've gone through those. And Becky, if there are questions about that, we can put in writing for them again. But the thing that I want to remind you on this in particular is that you have to have it where you can find it quickly for an audit. In nursing homes, they have it on one form, so they can provide an audit team that one form. Some of you have it on one form, but I've heard an awful lot of swing beds that have the initial certification in their physician orders, and then they switch to paper to do the form that the nursing homes normally do to do the 14-day. That is 2 different places, and whoever's pulling the information for an audit, do they know that? Do they know that they have to look in that physician order and they have to look on the form for the 14-day signature? So I would be checking internally because you remember this particular TPE audit and a lot of the other audits come to your business department. They don't come to the clinical side. They will involve probably medical records, but that doesn't mean they're going to involve those of you that are frontline clinical. I think you need to kind of look at a separate audit for yourself or a self-check to see where the cert and the recert are in your chart. Does everybody know that? Can you educate your billing department? Give them a sheet of paper and say, look, if there's a question about physician cert, give us a call, but here's the 2 places you can find it. So I hope that makes sense. But once there is not a physician certification that has been signed, sealed, and delivered the way it was supposed to be, that stops your Medicare payment. So if the 14-day they can't find, you get paid through day 14. But if, say, you keep somebody 16 days, 18 days, 22 days, you will not get paid for any of those days. And it's a technical denial. There's no appeal process to this. So it's really critical, whatever your process is for getting the original certification and doing the research, that you double check it now and make sure everybody's educated in that. Becky, has that raised any questions?
Yeah, there's one question here in chat. Can you please clarify what nurse practitioners are able to sign as far as admission and/or discharge orders?
They are allowed to sign. That is dependent on their state practice acts. And Becky, I think we've looked this up before. So the quickest way is to ask your nurse practitioner. All of you should know your state practice acts anyway, but ask the nurse practitioner. There are some federal rules where some of the forms have to be signed by a physician first. They have changed those in recent years. Again, your NP should know that. If they don't, I can take the time and go pull down the federal rules. And Becky, I think you can help with the state regs if needed. But
Yeah.
It isn't straightforward. It's not the same across 50 states, which is why I hesitate to say anything.
And as
Good question, though.
As nurse practitioners are signing admission and/or discharge orders, making sure that that's also addressed in policies and procedures. So
Absolutely.
yeah,
Absolutely.
well, I will double check with the state and look back at past answers to that, and I'll provide a follow-up when we send out the recording to the event. So I just want to double check before I respond, because it's been a while since we've addressed that question, and I want to make sure that nothing has changed.
Yeah, and I do remember you looked it up at one point because I will not, when we get into state regs, I can go look them up, but I don't have them anywhere near my head because everybody's truly different.
Right.
All right. So the other thing I want to remind you of is there is an audit that is ongoing and has been ongoing for years for both PPS swing beds and critical access. So the PPS swing beds are more often falling under that TPE audit that I just showed you. But one of the audits that goes to critical access hospitals in general, which means it can go to critical access swing beds, is that you have to be in compliance with the Medicare conditions of participation, or COPs. And if you're not in compliance with that, then there can be some substantial fines involved in that. I'm going to show you that in a second. In fact, I sent it to Becky. I sent everything late, and I apologize. I had some recent surgery, and trying to do work with one eye has slowed me up. I don't know how the pirates could fight that well with a patch on their eye, but I haven't learned that skill yet. So please know that somewhere part of your review process during the year should be team training on what the conditions of participation are. Because what the conditions of participation mean, if you're not in compliance with that, first of all, Medicare and Medicaid don't have to pay you. Second of all, if you're really out of compliance, you would be removed from the Medicare and Medicaid programs. And it has happened in our country, and it happens every year in our country. I have not seen it for Swingbeds. I've seen it for nursing homes. So please make sure your compliance people are aware of that. And I'm going to try and, let's see how I'm going to do this, Becky. I'm going to try and pull up the, I'll tell you what, I'll do this. Yeah, I took us totally out of it, didn't I? Let's see if I can just pull this over and make it large. That's probably the easiest way to do it at this point.
There you go.
This will be in your handout. Good. This are the these are conditions of participation. This is called a crosswalk because they changed some. So you see what they called an old tag number and to a new tag number. There have been a couple changes, I don't think, in critical access recently. That columns are there. But you will see, here's the regulation. Here's what they say is a part of the participation that you may need to do. So let's go down to this one. Be in compliance with federal, state, and local rules. And that is a condition of participation. So this is the column that you want to make sure you're in. And as Becky pointed out earlier, that means we should have regulations somewhere, and your compliance people should have this list. They should know what could be hitting the door. It is a fairly lengthy list. And I don't think all of us realize the depth of the list. So under leadership responsibilities comes infection prevention, not just under infection prevention tags, but under leadership. And that came from the antibiotic stewardship rules that passed a couple of years ago. Even though you don't have to complete the MDS and you're not doing the QAPI rules, there are still quality measures that they're expecting to be, I don't know, we're waiting for the MDS to be released. I think the new one will be 2023. They're going to update the quality assessment at that point. We think that may be the point they take critical access to a quality metrics also. But all I can tell you is we think at this point. So just know that that's coming. Here's the discharge planning that you can see, and the list is, as I said, lengthy. You will have a copy of this. Your compliance person should have a copy of this because these are the things that can legally get you kicked out of the Medicare and Medicaid programs. It is a rare event. But in some of these, there may be things that when your compliance officer looks at it, we don't have the right policy or we haven't updated a policy. So like Becky said, paper is easy for them to look at when they come in to review. So they'll ask for policies. That's why they ask for charts. That's why they ask for claims, because they can start there and start looking at additional things. So I also wanted to talk about some additional Swingbed audits that are going on. I can move this one over now. Across mostly the nursing homes again, but there are some that are related to the critical access wing beds. So this is targeted reviews. And if you ever see this, they'll come with a number. This is that discharge to community Remember, we have a set of rules about what we have to do when we're discharging. Right here, the reason I have put this is in the current target reviews. This is the only one that mentions swing beds, and it says that swing beds, your critical access swing beds are an exception. You're not going to be under this audit. So if it comes up around you, there's the information for that. However, these others have been standards, and you already heard me refer to a couple of them. Again, you're not under the PDPM if you're critical access. So just remember that audit shouldn't affect you. We do have state surveyors that come in every once in a while to a critical access swing bed and ask for the MDS or ask for information like that, because we have 16,000 nursing homes in this country, and that's the audit that they're most used to. They've gotten better in the last year, but for a while it was pretty constant. We've already talked about the importance of physician certification. I'm going to suggest again that you should be reviewing some of yours and review your process. And the reason this audit is out there, it's a targeted audit right now, is CMS has found 90% of the swing beds have physician cert errors, 90%. And when they see that, the dollar signs light up, because they can take back dollars for you. So please take that seriously to do an internal review on that. And Becky, if we need to do additional training or something I can put in writing for them to follow, just let me know. The other areas that we've been talking about this all along, is the admission and discharge. For instance, in the admission packet, having the choice of providers, even if you have a hospitalist, you have to explain why or for instance, their PCP may not be allowed to admit, not have chosen to admit for hospital patients, et cetera. And remember, your discharge notices have to be given to the patient timely if needed. And the ombudsman gets a copy of the discharges. We've talked about that also. And I know Becky's looked up the information for you in the state. We have been talking about abuse, and then also the trauma-informed care being the newer part of this in the last 16, 18 months. Just make sure your policies are up to date and that you're doing whatever your policy says as far as training. I don't know if it's quarterly, semi-annually, annually. That will depend on yours. You should be reviewing your policies and procedures. You can't believe how many times I go even into nursing homes and I find a policy that was written in 1971 or 1981 that's still in that book. It should at least be put in the new format to make sure everything's correct, but double check that. And we've been talking for the past year about the importance of the plan of care and the importance of your interdisciplinary team and the involvement of all those key individuals. And this will go plan of care and IDT. In this audit, they will be looking for the documentation. So those at the bottom, those four are reviews that you could get caught up in this next year. So I'm going to stop there because I really, literally, that's all I could find, which I think is really good. You guys don't understand. Nursing homes have right now 37 different things they can be audited on. So your list is shorter. It's things that we continue to talk about, and I would suggest that you need to talk about internally and not take anything for granted. It even goes to reviewing a chart once a month or once a quarter with your team so that everybody can see where maybe there's a weakness that can be improved. This is one of those continuous improvement type of activities. And I would really start again with the physician cert and the medical necessity. If they're finding 90% errors there, they will be reviewing all of that. So Becky, that's a lot just in a couple of pages. That's why I've provided the extra slides that they can read, or information they can read separately or work with their staff. And particularly, again, you need to get your compliance person probably this material, because if they need to study something, figure out something, ask you questions, they too will be ready. I've heard from 11 compliance officers this month. That's rare for me. I hear from maybe 2 or 3 a year, asking questions on things they have been asked by audit teams in Swingbed. So there's a lot of activity. I will tell you, if you don't want to say it out loud, again, I'm pretty upset enough that I have commented to CMS directly. That's the cool thing about being old and having cancer 6 times, Becky. I mean, what are they going to do to me at this point? So I have complained to CMS about the fact that they have elected to do this many audits for 2020 and 2021 when we were literally in the worst time period in our modern history of delivering care that people needed. In other words, we were trying to take care of people and not necessarily always dotting the I's. So that's where I'm going to stop and see if there are questions, comments. Becky, maybe again, some of this, if the questions come up later, is there more material that is needed, or is there a training module or something that may be needed to stay current with all this? I think you're muted, Becky.
I most certainly am. I mute and unmute so often I lose track. Please chat in any additional questions that you have, or just unmute your line and jump right in. And while you're thinking about those questions, Kerry, we might address, we've been hearing from a few hospitals recently that they've been having some challenges around Medicare Advantage programs approving swing bed admission.
Yep.
And we had talked about assessing the home environment. So I don't know if you'd like to describe that, and then I'll share the response I received from the state.
So let's take that separately. If you have a pattern of Medicare Advantage not paying you, most of them are paying slowly, let's put it that way. So I'm saying not paying you. But more particularly, I'm curious what they're asking critical access for, because they're asking the rural hospital swing bed programs to change the PDPM score that they got, which is illegal, by the way. You cannot change a PDPM. It comes from whatever the MDS had on it, and it spews out this score. I've got 3 different states where we have started, and we've gotten the Medicare Advantage billing experts in those states, and we're gathering the claims to go to CMS directly. So it would be very helpful if you are being questioned by your Medicare Advantage, or if they're paying slowly. If you can give me examples, again, send the examples to Becky and make sure none of the patient name or your information's in it. And Becky, you can double check that before you send it to me, because I send things on to CMS, but I don't send anything that has a location, a name, a patient name, a name of a facility. In fact, I can't even tell you all the tricks I played, but I've got 2 or 3 people inside of CMS that are now, in the last 2 years, forwarding what I'm sending them. I've got one going up a chain now, because they didn't understand the question, I think, but it's gone up a chain 3 times. So I have people inside that will follow that up. We do have a problem with it, but we need some data. So the more that you can provide, Becky, on non-payment, that will help us. Home evaluations, Becky, it'd be interesting to see what the state said, because that can be state regulated. The question that we've had mostly with home evaluations is the lack of time to do them now. Because of the pandemic, we've all been working triple time. Many of us are understaffed in most of our departments. That's where I've had some discussions, and we are getting families to bring in pictures of the surfaces that they have to walk over, the distance, for instance, from a bed to a bathroom, the height of a bed, where is a microwave on a countertop or above a stove, all those things that could cause difficulty for a person when they return home. I do think home evals are very, very important, and becoming actually increasingly important as we are an aging population. We have a lot of elderly people living at home alone or living with an elderly spouse, more so than we had 20 years ago by far, and that number is only going to increase. The other thing that's going on is we have multiple comorbidities, so they have more chance to get lightheaded, for instance, or sick to their stomach, or something that might cause a fall. So Becky, what did the state have to say on this?
So the question had come up regarding just a general assessment of the environment. You know, are there rugs to be removed or cluttered? Does the home even have
Right.
electricity? Like the distance they would have to walk from their bed to the bathroom, you know, is that farther than what is there at the hospital? These would be questions outside of physical therapy going into the home and assessing for DME needs and those kinds of things. But their response was, because we wondered, does it require a certain licensure to be able to conduct those types of assessments? And their response was that they do not currently have any licensure rules that specify who that individual needs to be to do those types of assessments, but they will look at the policies and procedures and see that you're following your policies and procedures for doing those general types of assessments to make sure what their ability in the hospital is compared to maybe the height of a bed at home. Is there anything different that needs to be done? Doing measurements and coming back and providing that kind of information. No specific license is required.
Right. It's usually been, and in a lot of states, they use the OTs to do that because they can do the measurements for PT, and OT is looking obviously for safety and transfers and bathing and cooking and sort of real life things. I will tell you the one line that you cannot cross is if the house shouldn't have people in it. In other words, it doesn't have running water, it doesn't have electricity, there's a hole in the roof, the steps are unsafe. That is not under the bailiwick of our programs. We have to refer that to whatever your state social services or, you know, local, that's their work. So if you realize you're going into a home that's not suitable to live in, that does have to be reported. And Becky, that may be county by county, but that does need to be reported. And then, you know, we have to decide what we're going to do with that individual long-term. That's when the state gets involved in that side of the process. I will say, because of COVID, we obviously stopped a lot of home visits. Because we're short of staff in so many places, we may not be able to ramp back up to home visits anytime soon. So I think getting a form, a cheat sheet developed that has questions on it for family members or neighbors to check for you. They can measure, you know, the distance. They can measure the height. They can look at whether you're going from carpet to floor, carpet to tile, and what that might mean for somebody walking and or on a walker. But I would be trying to get their assistance. Just the fact that you have several pictures, I will bet my bottom dollar every therapist and every nurse that's listening in will see something in that picture pretty quickly, like a stack of magazines, you know, right by the bed that need to be reviewed. As Becky just said, loose rugs, that sort of thing. So that, for this time period, may be the best alternative to make sure we can send somebody home safely, and in the process, educate them, you know, what they have to be watching for.
Mm-hmm. Kerry, I don't see any other questions in the queue, and we're really right at time for today. So everyone keep the questions coming in. Glad to assist you as we can. A big thank you to Kerry for sharing all of this wonderful information. I will make sure that the additional documents and the presentation are attached to the follow-up email that includes the recording link. And we want to wish everyone a happy day and stay safe. We sure appreciate everything you do. Thanks so much. Bye-bye.